Hello and welcome to the Unit 6 lecture on culture, diversity, sexuality, and ethical issues in the healthcare setting. So the U.S. Census predicts that by 2050, the Hispanic and Asian population will have both tripled, the Black population almost doubled, and the Caucasian will barely hold its own. The U.S. is rapidly becoming more racially diverse. As nurses, we must be prepared to meet the needs of clients from various cultures and backgrounds. It's important for nurses to understand how culture affects behavior so we can provide both culturally competent and holistic care to our patients. There's several learning objectives for this unit. There's a link to them on E360. You can print off and jot them down. But it's important to know them because we need to know how to work with different cultures, and we also need to know how to practice according to our legal and ethical boundaries. So it's important to understand the meaning of culture. This is the values and beliefs learned and shared by a particular group of people. For example, in Western society, we consider the color white to be purity or clean, or an angel, a nurse. Chinese considered white to be the color of death. Physicians still wear white lab coats to symbolize this, but they wear dark clothes underneath to symbolize authority. Additionally, it's important to understand ethnocentrism, which is the tendency to view one's own culture as the correct standard to view other cultures by. The ANA sets standards for dealing with cultural considerations. What does this mean? Be aware of the culture of those we serve and try to decrease cultural barriers. This is a component of culturally competent care. Some cultural barriers to effective communication are especially challenging. There are 3 ways culture interferes with effective communication. One is cognitive constraints. Our worldviews may be different than others. A second is behavioral constraints. For example, standing close to someone or making direct eye contact can be a problem depending on the culture. And the third is emotional constraints. Regulation of emotion may be different depending on the culture. For example, the client may yell, wail, cry, or act out versus show stoic behaviors when confronted with a crisis. Remember from week 1 that holism is caring for the whole person as a part of their environment. The ANA standards of practice help guide nurses to practice holistic nursing care. Culturally competent care in nursing. To be culturally competent, the nurse needs to value diversity, be conscious of the dynamics that occur with the interaction. They need to have some kind of knowledge of the culture and have adaptations in place to deliver competent care. Cultural awareness is when the nurse becomes sensitive to the values, beliefs, lifestyle, and practices of the patient and explores their own values, biases, and prejudices in relation to the patient. Unless the nurse goes through this process in a conscious, deliberate, and reflective manner, there's always going to be the risk of the nurse imposing their own cultural values during the encounter. And we want to try to minimize this whenever we can. Access is a tool used to guide nursing practice. So for your assessment, think about the culture of your patient. What part of their beliefs or lifestyle may contribute to the disease? An example is a person with heart disease. What factors are modifiable? Things like diet, exercise, smoking, stressors, versus non-modifiable, like gender, family, history, and age. The goal is to generate from a patient's information an understanding that enables the nurse to provide culturally congruent care. This means the care that we give aligns with the cultural preferences of the patient. Try not to ask global questions like, do you have any cultural practices we should know about? But instead you want to try to ask specific questions about cultural practices, such as, what meals does your culture, or what meals do you want to eat according to your cultural beliefs? Or do you have religious rituals or bathing or herbal supplements that are an important part of your cultural care? This allows greater details by the patient about their cultural practices. So if a patient requests a particular cultural practice, it is okay to accommodate their request as long as it won't cause harm or a safety concern. There are many cultural aspects to take into consideration when caring for patients. Patients from some cultures feel they deserve pain due to wrongdoings committed by the patient, so they may be reluctant to take pain medication. Also, some cultures allow warm foods or cold foods depending on the illness or health concern, so this is something to take into consideration also. It's always good to have a general idea of the culture of your patient, but we want to be careful not to stereotype the patient. Verify the cultural beliefs of your patient regarding health and illness, and then act on them as you're able to. The dominant American culture values assertive and direct communication. Other cultures value group harmony, respect to elders, and other priorities. Remember that verbal communication can differ also. Vocabulary, tone of voice, rhythm, speed, sharing of private information can all vary depending on the culture. The patient might need an interpreter also if they're not an English speaker. Remember, nonverbal communication differences are there as well. Touch, eye movement, facial expressions, body posture, and space orientation all can mean different things for different people, so we need to be sure of what is the comfort level of our patient. So when assessing individuals from different cultures, it's important to remember that each individual is unique and cannot be stereotyped according to their culture. We need to fully assess what cultural beliefs they want to have incorporated into their care. Don't just assume. Also, look closely at your own views towards a particular culture and try to remain neutral. Another important aspect of assessing diversity is assessing the patient's developmental stage. We must adapt our nursing care and approach based on the patient's developmental level. And one way that we can do this is by paying attention to Erickson's psychosocial stages. And this slide just walks you through the different age groups and what they are, and then we have favorable outcomes versus unfavorable outcomes if they meet this stage or not. So look at this case study, and I want you to think about how you would respond to the questions at the bottom. Pause here and please send me an email outlining these 3 questions, give me their answers, before class starts on week 6. This quiz is worth 5 points, so make sure it's turned in before class starts. Before assessing your patient, determine or observe their language, communication patterns, space orientation, verbal and nonverbal aspects, and roles. Potential nursing diagnoses for these patients include impaired verbal communication related to cultural differences, impaired social interaction related to sociocultural differences, and noncompliance related to patient value system. But for this diagnosis, we need to ask ourselves, whose patient value system is it? Is it ours as the nurse, or is it the patient's as their culture dictates? And then also risk for loneliness related to social isolation. Consider some ways to be culturally sensitive. For example, Somalians prefer the family to be informed instead of the patient. Muslims believe that when a person is dying, their head needs to be turned in the direction of Allah. Family members of the same sex cleanse and care for the body of the deceased. For Muslims, family reads the Quran. Some cultures believe the deceased body is to be buried intact. However, in the U.S., upon death, the family is asked about organ donation. This is a regulation. This comes into play if we're dealing with patients that maybe have this preference. And one time I was caring for a Mexican migrant worker that got declared brain dead, and I spoke with his mom on the phone and asked her about organ donation, and that's what she told me. She said no, she didn't want the donation because she believed he had to be whole to go to heaven, and donation would have prevented that. So even though this is not my personal belief, I had to respect her beliefs. For a patient with a language barrier, provide interpreter services. Always use materials and teaching techniques that are culturally relevant for the patient and family. In order to complete the assessment, you may need a translator. Perhaps another nurse speaks Spanish. Ask your resource nurse. If there's no translator available on site, you can call a language line and ask for someone who can speak the patient language. These are just some things you can think about if you're dealing with the implementation phase. Cultural competence is best achieved when you're able to reflect on your own belief systems and avoid judging others based on your own experiences. If you face a situation that you're not comfortable with, it is okay and appropriate to discuss this with your supervisor or peers to work through it, or you can request a different assignment if possible. This slide lists some other ways to increase cultural competence as well. You have the ability to positively influence a patient's self-concept and body image, especially after significant changes. So we have a direct influence on the patient's self-concept and on their idea of sexuality. So one such change that you might come in contact with is a mastectomy. And then another one is if we are doing maybe an unpleasant task such as changing an ostomy bag. We want to anticipate our reactions to these unpleasant tasks, and we want to focus on the patient and not the task. Be aware of common conditions and medications that can impact a patient's sexual health also, and use therapeutic communication to open the discussion. Make your patient feel like what they're feeling is a normal feeling and encourage them to talk about it. So what are some therapeutic techniques we can use? Well, we can use active listening, clarifying, and reflection, and we can avoid making assumptions. The bottom line is, if you feel like you can't help the patient, find out what your available resources are. Perhaps a counselor on staff or a referral can be made, but we shouldn't just leave things as they are. They all need to be addressed. Standards of care are the expected level of performance or practice as established by guidelines, authority, and custom. If involved in a malpractice trial, the court is going to inform the jury about standards of care. The jury then is going to determine whether you acted the way a reasonable nurse would have acted in a similar circumstance. In a court of law, it is described as what a prudent nurse would do. The term reasonable nurse refers to the training that all nurses receive. Professional liability is covered by your employer, but this does not cover things that happen outside of work. Liability insurance is relatively cheap and is recommended to cover these things. Patients do sue for compensation for a variety of things, such as medication errors, retained sponges, inappropriate delegation resulting in harm, and falls, among other things. Remember that the nurse is still responsible and can be held liable for carrying out a physician order if the order is not appropriate and causes harm. So we need to stand up for what we believe to be right. Stay current with continuing education and regulations. Thorough and accurate documentation and avoiding pre-charting, as well as thoughtful, accurate communication can all reduce the risk of litigation. Another area nurses can get in trouble is with patients' valuables. Agency policy dictates what documentation is required, but it's really good practice to fully document what valuables are present on admission, on transfer, and on discharge. This protects you from the patient claiming that they brought valuables with them, such as jewelry, pills, or money, and then now they come back and say that they're missing. So if we chart nothing brought to the hospital with the patient, that's going to protect us in that case. Consent forms require special care. If you suspect the patient doesn't understand the procedure or the patient states that they have questions, you need to notify the provider. The patient is never coaxed into sign, and it is not the nurse's scope of practice to provide details of the procedure. As an example, I cared for a lung open heart surgery patient going into surgery, and the family wanted to talk to the surgeon first. The surgeon was upset with me that it was delaying surgery, but as a patient advocate, I would not let the patient go into surgery without the physician talking to the family first, because the patient had questions, and this was truly the way the procedure should have went, was answer questions first, procedure second. Autonomy is the right of patients to make decisions about their medical care without the provider trying to influence their decision. Patient autonomy does allow for the provider to educate the patient, but it does not allow the provider to make the decision for the patient. A DNR means do not resuscitate. You need to always, always, always know the code status of your patient and act accordingly. DNR does not mean do not treat. DNR patients can still have life-sustaining treatments like IV fluid, vasopressors, and antibiotics. If you're unaware of the code status, you need to provide CPR until the code status can be verified. Community DNR bands are metal bracelets that are worn outside the hospital, and these signify that the patient does not want CPR if they experience an out-of-hospital arrest. This, though, requires a physician order and paperwork sent to the state, so it's not something that the hospital can just hand out to the patient. And then the Patient Bill of Rights outlines specific rights that each patient has when they're receiving health care services. So part of our job is to advocate for our patients to ensure that their rights are upheld. This can be by adhering to their wishes, obtaining a social worker consult, and moving up the chain of command as appropriate. This would be in the direction of provider, then supervisor, and then on up, and eventually it may even get to an ethics committee if appropriate. Good Samaritan laws state that if you act within the standards and in your scope of practice, you're not going to be held liable for a bad outcome unless, and this is the key here, unless there's evidence of gross negligence. Nurses are not required to render help, but it might be considered an ethical obligation to do so. Once you're assisting, though, you need to continue to assist until qualified help arrives, such as EMS. And this is just a side note, but emergency assistance also is not covered by an employer's malpractice insurance policy, but it would be covered if you had privately held malpractice insurance, which also is recommended. And then as a reminder, HIPAA stands for Health Insurance Portability and Accountability Act, and we have an ethical and legal responsibility to maintain patients' privacy. You can look back to scope of practice for more detail on HIPAA and HIPAA violations. And then the last thing here is reporting obligations. Now, nurses are mandatory reporters for suspected abuse, neglect, and this would be of minors or of at-risk individuals. And then also we need a mandatory report if we're working with an unsafe or impaired professional. So if another nurse comes to work drunk or intoxicated, we need to report these, and we have an ethical obligation to do so. Ethics in nursing are principles that serve as a basis for decision making. These are various ethical principles to be familiar with, so just go ahead and look through this and make sure you understand the definitions of each of these. So the ANA, or American Nurses Association, sets the standards of care which are considered guidelines for patient care. It's very important to treat all patients with dignity and respect regardless of why they're being seen. So for example, imagine if you had a drunk driver in the same unit as a patient that was struck by the drunk driver, and now that patient is on life support, not expected to survive. You need to treat both patients with compassion, respect, and dignity, even though that can be a little bit challenging. And this did happen to me once in my practice. And in this case, what we did was we put the patients on separate ends of the unit to decrease family conflict so they didn't have to share waiting rooms and pass each other in the hallway. Review the ANA Code of Ethics. This was discussed under scope of practice as well. Ethical dilemmas are bound to happen when we're caring for patients. It's just a part of the nursing game. The ethics committee can help to solve some of these ethical dilemmas. The ethics committee gathers all the information relevant to the case, and they consider possible courses of action and then help to decide on a course of action. In managed care, monetary incentives are used to affect physician behavior, and sometimes this can be including rewarding physicians who practice medicine cost effectively by offering financial rewards such as bonuses for those that provide the most cost efficient care. Now, sometimes this is a conflict of interest, so this might be something that would get brought up to an ethics committee. For end-of-life care, patients and their proxies should exercise control over decisions regarding the use of medical interventions that may prolong existence rather than to allow a natural progression of the dying process. The traditional value to preserve life by all possible means is now being weighed against patient-centered quality of life considerations based on evidence-based care and a shared decision-making process. It can be very difficult when the treatment plan is prolonging death rather than saving lives. And this is something that we as nurses need to just kind of get a check on our feelings about. An example of that would be resuscitation on a patient in a persistent vegetative state at the direction of the family. This was a major ethical dilemma for me that I had once, and fortunately in this case the family was present when the patient did have a cardiac arrest, and they allowed us to stop CPR. That's not always the case though, unfortunately. Stay in tune with cultural sensitivity. Many cultures dictate that the health decisions aren't made by an individual, but they're made by a group, the family, the community, or their society. The ethical principle of autonomy is related to self-determination, which is the individual's right to make decisions for themselves. And consistent with this is a principle of respect for the autonomy of others. So if we have a lack of respect for the decision-making of culturally diverse people in nursing practice, we're practicing unethically. An example of this would be a Jehovah's Witness that does not accept blood transfusions. Providers can be sued for giving blood if the patient did not agree, even if it's to save that patient's life. So we need to keep all these things in mind. An important aspect of nursing also is delegation. We've talked about delegation before, but we know that delegation is a major element directing everyday function of nursing and their workflow. It's a competency by which nurses encourage and motivate others to get the job done. The legal and ethical implications that go along with delegation are huge, though. When delegation occurs, responsibility for the care is transferred to the delegate, but accountability for the care remains with the one doing the delegating. So this is an important point because the individual delegating an assignment has to make sure they're delegating to people who are competent in the skills needed to complete the assignment. And then we also need to make sure that it was done and we follow up on it. So an end note about all this ethical dilemma and ethics is we need to really just examine how we feel about end-of-life issues, examine how we would go about caring for patients in ethical situations. And this concludes the presentation on diversity, culture, sexuality, and ethics and legal. Have a great day. Thanks.